Wait.
Okay, I'm ready to go. Okay, so today we're going to be talking about COVID-19 in Maine and healthcare for underserved populations here. So first, it might be helpful to talk about kind of what it means to be underserved in your access to healthcare. Communities who are underserved are people whose ability to access healthcare inhibit their ability to achieve quality outcomes. And in Maine, by statistics, there are a lot of underserved populations. These include groups like the elderly, low income groups, rural communities, and disabled people. And when it came to deciding on which population in particular we wanted to focus on, we were informed in part by HRSA, which is a federal organization, and they designate certain areas as medically underserved. Maine contains 52 of these areas, and all of them are designated as either rural or partially rural. So addressing rural healthcare in Maine is really important. Today's presentation will begin with some background and statistics on what rural healthcare and COVID-19 look like in Maine. Then it will go on to a community assessment and an analysis of what kind of main shortcomings are and where areas that the slack needs to be picked up. Then we'll go on to some proposed interventions and then an evaluation of how feasible implementing these interventions might be in Maine.
Okay, so the United States spans about 3.5 million square miles with 332 million people. In America in 2020, 57 million people lived in rural areas, and Maine, which is the northeastern state of the United States, spans about 35,000 square miles and has over 1.39 million people living in it, with 550 of those in rural areas. So, poverty in rural America is a persistent problem. As shown in Figure 1, there's about 41 million Americans below the poverty line, which is almost 12%. And on a local level, 1 in 10 Mainers grapple with poverty. So, on the next slide, in Maine, regional disparities exist, with Washington County having one of the highest poverty rates at 18.7%. As shown in Figure 2, contrasting the least poverty counties, which are Cumberland and York, in white, and both are urban areas. According to an article in 2019 by Rebecca West, it states that Washington County's poverty rate was 19.6%, which was well above Maine and United States average. For the next slide, Washington County residents identified primarily as white non-Hispanic, with American Indian and Alaskan Natives at 5.3%, Hispanic and Latino at 2.6%, multi-ethnic at 2.1%. These minorities nationally and statewide face higher poverty rates and COVID-19 impacts. According to the CDC, in rural America, higher COVID-19 case rates have been observed in certain minority populations. So, for the next slide, low-income individuals experience a higher burden to chronic illnesses due to limited access to preventative care. Low-income individuals in rural Maine, particularly in Washington County, face challenges accessing health care, as rural Americans have the highest rates of poverty, unemployment, and lack of insurance. In Washington County and rural America, resources are limited, healthcare infrastructure is often underdeveloped, which is resulting in long travel times and sparse medical facilities. An article titled Telehealth for Chronic Disease Management Among Vulnerable Populations that states that difficulties in accessing healthcare services are a long-standing challenge in the U.S. healthcare system. According to an article, also, it stated that non-Hispanic Black patients experience health disparities and low income. Nationally, Blacks have the highest poverty rate at 17.1%, followed by Hispanics at 16.9%, which is almost double that of non-Hispanic whites. In Maine, as of October 2023, COVID-19 cases for Blacks accounted for 12.6%, but the Black community only accounts for 2.9% of Maine's overall population. This indicates that Blacks are 6 times more likely to contract COVID-19 than white non-Hispanic individuals, as shown in Figure 3. Furthermore, Hispanic and Asian Mainers experience COVID-19 rates at double their share of the population. In the next slide, as of October 30th, 2023, Washington County, shown in Figure 4, had the highest rates of COVID-19 cases at 3.8 people per 10,000, and one of the lowest per capita hospitalization rates at 0 hospitalizations for every 12th person. This further emphasizes the growing gap that exists between low income and minority individuals and their ability to access medical care. Fear of contracting the virus at healthcare facilities, coupled with concerns about lost wages and high healthcare costs, deterred individuals from seeking necessary medical care. This reluctance to access healthcare during the pandemic not only jeopardized individual well being, but also posed a public health risk. The pandemic underscored the urgency of addressing healthcare disparities and access issues in rural areas like Washington County. On the next slide, one factor that contributes to this widening gap is a lack of healthcare providers in rural areas, coupled with the high turnover rates. According to Rebecca West's study, participants identified a lack of clinicians, along with the difficulty of recruiting healthcare professionals. High turnover rates existed due to limited clinicians being overworked and then underpaid. As expressed by clinicians in Washington County, turnover is accelerated in a rural community health center because the level of need that you're seeing in patients is so enormous, as opposed to a place that might have more resources. That adds to a very quick burnout, and then if you're not recruiting providers who have been in rural areas, they don't appreciate that lifestyle and they leave. So the absence of nearby hospitals is another barrier for rural Americans. The shortage of healthcare facilities and professionals leaving the community ill-equipped to respond to health emergencies such as the COVID-19 pandemic. And currently there's only one critical access hospital with 25 or fewer beds, which qualifies for federal financial aid. There are also 2 tribal health centers and 5 qualified health centers that offer primary and preventative care. Nationally, more than 138 rural hospitals have closed since 2010, overwhelming in states that have not adopted Medicare expansion. So the lack of hospitals close to home makes accessing medical services very difficult. This explains why Washington County is the lowest in health rankings within Maine. Over time, poverty among low-income and minority individuals is going to keep increasing. Thus, addressing poverty and healthcare disparities in rural America, particularly in Washington County, is imperative not only to enhance the overall quality of life for these low-income individuals and minority residents, but also to bolster the community's capacity to respond effectively to the public health crisis, such as COVID-19.
The plan for the community assessments is to promote access to healthcare, especially for those who are underserved and low-income people, and to improve health of everyone in the community. The assessment of the community was done through data collection and windshield survey. The increasing attention is being paid to the disparities in healthcare and healthcare outcomes experienced by approximately 57 million rural Americans. In particular, the COVID-19 pandemic has laid bare the deficiencies in public health, clinical care, and infrastructure and systems between rural and urban areas. Hospital closures, lack of transportation, clinician shortage, and insurance policies has contributed to the significant barriers to care faced by rural Americans. The data used in this study was collected from Washington County, the most easterly county in Maine, with large tracts of organized territory and a limited road infrastructure. With a population of 32,000, Washington County consistently has the worst health rankings in the state. As of 2019, its poverty rate was 19.6%, well above the average of Maine and the United States. Washington County residents identify primarily as white non-Hispanic, with notable American Indians, Hispanic, and multi-ethnic populations. In this county, there is no large hospital that is primarily responsible for providing health services. There is one critical access hospital with 25 or fewer beds, 2 tribal health centers, and 1 bus stop located 20 minutes away from the residential area of the county. In the next slide, the strength of the community Participants described successful collaborations between government and health systems, including creative efforts to use limited resources in a wide variety of settings. Active networking and collaborations included a critical access hospital, hosting quarterly meetings of local clinicians and regional emergencies services regarding COVID-19 response. The concerns of the community were the problems with lack of transportation to hospitals, poor availability of broadband internet for telehealth services, and limited resources and staff for healthcare centers in the community. In the next slide, the community diagnosis of the main problem for the underserved populations is accessibility of transportation and allocation of fundings to the community to support healthcare professionals to stay locally. The three key priorities for sustaining and restoring healthcare services to this population include addressing maldistribution of services, providing healthcare and social services in the community, and legislation regarding insurance scope and practice.
Okay, now I'm gonna discuss our goals. So Grace just discussed the barriers people face when receiving care, such as transportation, poor internet, and limited resources. To address these barriers for our short-term goals, we proposed improving access to healthcare through the use of telehealth kiosks and paramedicine. COVID-19 significantly affected chronic disease management in underserved populations. Studies report a 40 to 50% decrease in overall hospital readmissions related to chronic disease during the pandemic. However, there is a threefold increase in mortality rates. For our long-term goal, we hope to see an improvement in outcomes in chronic disease management. Next slide. Our primary prevention is focused on disease prevention. We suggest implementing educational programming that could be provided through phone, text, and telehealth kiosks. This could include informational health coaching sessions aimed at promoting health literacy. Another intervention based on primary prevention is the use of paramedicine for the administration of vaccines. Community paramedicine in rural areas can help fill the gaps in healthcare, addressing shortages of primary care physicians. EMS personnel can provide non-emergency care focused on prevention and screening. Primary prevention in the rural and underserved communities is especially important because of the barriers faced in accessing healthcare. Many individuals will postpone and forgo seeking care until later in the disease progression. Next. So for our secondary prevention is aimed at early detection and prevention of disease progression. EMS personnel could help with the administration of screening tests and assessments and early disease detection. This can include education about self-examination, such as for breast cancer. EMS personnel can do blood pressure screenings and glucose checks to screen for high blood pressure and diabetes. And telehealth and paramedicine can be used for disease management and monitoring care. Educating patients on healthy lifestyles and diet to prevent disease progression. Next. So this brings us to interventions for tertiary prevention. Tertiary-based interventions are focused on rehabilitation process after major illness, involving prompt initiation of treatment and follow-up care. Paramedicine and telehealth can help with chronic disease management and diabetes care, monitoring vital signs and physical assessments, wound care, and surgical follow-up care, blood pressure draws, COPD care, asthma management, and edema assessment, and more. By taking an interdisciplinary approach and helping patients monitor and treat their chronic diseases, we hope to improve outcomes in chronic disease in the underserved populations of Maine. Next.
Okay, there we go. So as everyone's talked about, our interventions are really focused on rural and low-income communities' lack of access to healthcare in Maine. And in her community analysis, Grace mentioned things like a lack of transportation, poor availability of broadband internet, and limited resources for health centers in the community as shortcomings of rural healthcare in Maine. And then Melanie proposed 2 attainable solutions for us to focus on in addressing some of these shortcomings. And those solutions are the implementation of telehealth kiosks and the potential of community paramedicine to address some of the shortfalls of transportation for providing basic care, specifically during COVID for things like vaccines and COVID testing. But the question that we need to address now is, does Maine have the resources to implement these changes in underserved rural communities, and especially in the wake of COVID? And what changes would we need to make in order to implement them? Does that work? So firstly, to address the lack of regional healthcare centers in rural areas and a lack of reliable internet access to telehealth, we've proposed the use of a wider spread implementation of these telehealth kiosks, which can help expand telehealth to people who don't have access to the internet or people who might not know how to operate technology sufficiently to use them. And in a perfect world, a lack of regional healthcare centers could be addressed by implementing more healthcare centers, but this is not necessarily financially feasible or possible with current staffing limitations, especially in rural areas. We need our goals to be achievable, and telehealth centers are much more feasible than massive overhauls to like Medicaid and Medicare reimbursement and finding a hospital worth of staff willing to move to work in places like rural Maine. So on this slide, I have a picture of OnMed, which is an example of a telehealth kiosk. It has these like clear doors that turn dark for privacy during sessions, and then they have ultraviolet light inside of them to help keep them clean. They use facial identification for patients, and then they have several automatic measurement functions for things like blood pressure, height, and weight. They're also equipped with high-speed internet and high-quality audio and video. A good place to implement something like this might be in a pharmacy. This company, OnMed, specifically states that they were looking to have these rolled out in places like hotels, airports, or college campuses. And telehealth kiosks can help bring internet access and our health service option to people that might have low technology capabilities who live far from healthcare. However, they don't entirely solve the issue of a lack of transportation or for primary care visits that might require in-person assessment for whatever reason. And so what can? Melanie mentioned community paramedicine in rural communities might be able to help us fill some of these gaps. And when it comes to evaluating Maine's ability to implement community paramedicine, Maine actually conducted a pilot program, which was put into state legislation back in 2012 as an act to authorize the establishment of pilot projects for community paramedicine. And the point of the program was to address how feasible it might be in helping to address the lack of transportation to primary care in rural centers as it kind of pertained to chronic disease management. And like we mentioned, it might be able to be co-opted for things like COVID vaccines, routine vaccines, or COVID testing. The potential of CP in Maine to be useful was first brought up in 2004, but it wasn't until 2010 that stakeholders willing to fund it were identified. And these were groups like the Maine Board of Nursing, the Maine EMS Medical Directors Board, and like Cigna Health Insurance. And when the program was enacted in 2012, it was set in motion for 3 years. And so on this slide, I have a table of all the different EMS services that were involved in this pilot program. And to the right of that is a table of all of their capabilities. You can see things like CHF screening and other kinds of chronic disease management that community health can help patients to keep an eye on. And one thing about community paramedicine that makes it really awesome and useful is that EMS personnel are already trained in most of the assessment techniques that are required for it. It just involves putting those skills to new goals. And one of the also amazing things about staffing community paramedicine is that with some additional training, like administering IM vaccines for COVID, EMTs are able to do most screening, which could really help staffing capabilities because becoming an EMT doesn't require that much training. And when it came to addressing the effectiveness of this program, St. Mary's chief operating officer said the program was really successful at reducing hospital readmissions and ER visit costs. So when it comes to obstacles that we might have in implementing these telehealth kiosks or community paramedicine, in the case of something like OnMed, which is the telehealth example I gave, it requires there to be providers licensed within the state in order to operate it. And we'd also need a location to put the literal kiosk. Like I mentioned before, ideal locations would be in towns that are lacking adequate internet or primary care service options. It's also important to note that telehealth doesn't replace primary care, but it can really help less tech-savvy people with low internet access really navigate telehealth, which is really important in this kind of aftermath of COVID where telehealth has become so huge. And when it comes to finding Maine providers willing to staff these kind of services, Maine Health saw more than 1,700 telehealth visits in the 3 weeks after the pandemic began in 2020. And during that time, Intermed PA also began seeing patients via telehealth, in which case there are plenty of providers trained and able to do telehealth in Maine. So I think staffing this intervention seems feasible. However, the main issue I see right now is that these telehealth kiosks are run by private companies, in which case patients wouldn't be able to continue seeing their primary care providers through these unless their primary care provider was like somehow licensed through the company. So I would like to see more general telehealth kiosks, like a Maine Health telehealth kiosk, where patients could continue seeing existing providers. And then when it comes to implementing community paramedicine, we've seen that the pilot program was really successful, but now we're looking to see sustained process. The biggest threat to that would be maintaining funding and support. Organizations would need to be just as in support of staffing and funding their CP programs as they are any other area of the hospital, which might prove to be challenging for like a program like this that's novel. And we'd also need to think about how to sustain staffing for these sorts of things. During the pilot program, the different EMS directors, the different EMS groups staffed their ambulances using a combination of paramedics, EMTs, and volunteers. And for organizations that depend on volunteers, it might be kind of hard to maintain that kind of staffing in the long term. So in concluding what our presentation has talked about today, COVID strained health systems all over the country, but in medically underserved areas like 52 regions of Maine, this effect was transformative. Maine's rural communities lack adequate primary care, transportation, and they suffer from staffing shortages. Solving the issue of rural lack of access is really difficult. So like, for example, telehealth boomed during COVID, but what about people in rural areas who might have a hard time accessing the internet, or older folks who might have a difficult time using web-based services? And telehealth kiosks can help bring telehealth to people who face these challenges. And then community paramedicine, which has already seen a pilot program in Maine, we've seen success in, and it might be able to help ease the lack of primary care and transportation, the lack of primary care and lack of transportation by providing home visits for basic assessments. So challenges still remain in staffing and funding these solutions, which will be additional obstacles Maine has to face going forward, but these changes might be more feasible and obtainable changes than completely overhauling Maine's healthcare system to build new centers in rural areas. So here are our references, and that concludes today's presentation.